So good morning, everyone. Thank you for joining me here today. And I would like to begin today's progress report with my PhD title, Dentofacial Anomalies and Intervention Strategies. My name is Borbély Eszter. I'm a dentist and a first-year PhD student, and I come from a city in Romania called Târgu Mureș, or otherwise known as Marosvásárhely. I belong in the Department of Oral Biology and Orthodontics, and I have a mission of setting the standard in dental anomaly management. My mission is to implement evidence-based practices to address and correct dentofacial irregularities. Here you can see my team who is helping me achieve these missions and visions. So I have two specific goals as of today. The first one talking about impacted canines that started in September, and the second one that's going to compare tooth-borne and bone-borne maxillary protractions. We also started that last year in November. The title of my first topic is investigating the safety and efficacy of opened versus closed surgical exposure of impacted maxillary canines, a systemic review and meta-analysis. So, an impacted tooth is a tooth that fails to erupt into the dental arch within the developmental time frame. The maxillary canine is the second most common tooth after the third molar. The prevalence is around 1 to 3% of the general population, which translates to a staggering 78 to 273 million people worldwide. Impaction does come with complications. First, I would like to address the functional issues. We can have problems with the occlusion and the bite. Again, if you're looking at the house and confused, well, let me explain. What's the most important thing when you're building a house? The pillars. They need to be strong to hold the structure and support the entire integrity. Similarly, in the oral cavity, the canine acts as this. It is the longest rooted tooth and has not only the aesthetic, but also functional harmony. Second, I would like to address the aesthetic concerns. It affects the appearance of the smile, and it just looks different. And now, I would like to introduce the third complication, which is the psychological impact, which can affect the self-esteem and the confidence of a child, especially if they don't look like their fellow peers. Now, the closed technique does have its own set of complications. It can be more difficult to direct the force, and if the unerupted tooth does impact against the adjacent tooth, we can have complications like root resorption, which is really unwanted. It can increase the treatment times, and the alignment time will be more unpredictable. What is the aim here? Well, the aim is to evaluate and compare the clinical outcome durations of the treatment phases and the patient-reported experiences between these two techniques. The clinical question that I have brought to you here today is, does open surgical exposure reduce treatment time and improve periodontal health compared to the closed technique for impacted canines? The population that we monitored was adolescents with an impacted canine undergoing surgical exposure. The intervention was open, the comparator was the closed technique, and our primary outcomes consisted of treatment duration and surgery time. Our secondary outcomes will look into more detailed timing for the eruption and the extrusion, the canine alignment. We will also look at the periodontal status, which is very important and sometimes underlooked, the failure, the re-exposure rate, pain, post-operative recovery, the speech and eating difficulties that may come with this. The hypothesis is that open exposure of impacted maxillary canines shortens the treatment time and improves the periodontal health compared to the closed exposure. Now, the clinical implication is to establish a treatment protocol to identify the most safe and effective technique. Here you can see my search key. It consists of two domains, the first including the population, and the second the intervention and the comparator. You can see the number of hits that we found on the 3 academic libraries and my key articles listed below. Here you can see a progress of my flowchart selection. We began with just under 10,000 articles, and we found 75 eligible full texts. Now we are still undergoing the citation chasing, and we have also additionally added the forward citation chasing method. Here you can see the progress of my first project. The data extraction is ongoing, and we are still waiting for the additional articles from the library. Now I'd like to introduce you to my second topic, which is evaluating the efficacy of tooth-borne versus bone-borne maxillary protraction in maxillary hypoplasia, a systemic review and meta-analysis. So what is maxillary hypoplasia? It, in short, is an underdevelopment of the maxilla and is often seen in skeletal class 3 malocclusions. The clinical presentation with this comes, as you can see, the man to my left With the concave facial profile, we can see mid-face deficiencies, and also functional issues do arise like malocclusion, speech difficulties, and compromised aesthetics. So the tooth-borne, or as referred to as the traditional method, does involve the use of generally headgear. As you can see, the child is not so happy. That being said, we are having patient compliance limitations, which I think can all understand why. With the tooth-borne method, we have limitations also that we're risking undesired dental compensations, like teeth tipping, which is also not beneficial. In the bone-borne maxillary protraction, however, we are using skeletal anchorage devices to apply the orthopedic forces directly to the maxilla, for example, mini plates, mini implants. And the advantages are, as you can see, that it's generally in the mouth and it does not always rely on external appliances. And the main advantage here is that it minimizes the dental compensations and it potentially has a more stable skeletal result. The aim here is to compare the clinical effectiveness of bone-borne versus tooth-borne maxillary protraction in the treatment of maxillary hypoplasia in growing patients with skeletal class 3. The clinical question is, can bone-borne replace conventional tooth-borne methods for maxillary protraction? Our population is adolescents requiring orthopedic maxillary protraction. The intervention is a bone-borne comparing to the tooth-borne, and the following orthodontic outcomes will be monitored. The hypothesis is that bone-borne therapies provide greater skeletal advancements, fewer dental compensations, and more stable long-term outcomes than tooth-borne methods. The clinical implication is selecting, again, the most effective treatment modality for skeletal class 3 malocclusion in growing patients. Here you can see my 4 key articles. All of them have the intervention bone-borne comparing to tooth-borne. And with that, I would like to summarize. My first project would most likely be submitted in September, if all goes well, and the second in next year of June. And with that, I would like to leave everyone with a favorite quote of mine from Steve Jobs: "The only way to do great work is to love what you do." So thank you for your kind attention.
So thank you very much for your presentation and for breaking the ice, being the first to present. So I have a question in regards of your first project. As far as I know, both of the interventions are quite painful, but I think that there might be a difference between them. Do you know which one is more painful and which one is more accepted by the patients?
Yeah, so pain is actually a bit of a two-way topic here. For the general surgery, I would say that the closed is more painful because generally more bone needs to be removed. However, in the long run, I think the opened intervention is not so painful. However, with the closed technique, it is more painful afterwards because the tooth actually has to break through the gingiva. And in the open technique, it does not. If that answers your question.
Yes. Thank you very much.
Thank you very much. Does anybody have a question? Okay.
Thank you for your presentation. It was really nice, and really thank you to be the icebreaker, to be the first presenter. I want to ask about the affordability and about the green dentistry. Which is more affordable? The open or the closed technique, and why? Is there a way, or is there any relevant information in the articles or in the general practice? What do you think about it? Because nowadays we can see that all of the companies, all of the health insurance companies, and everybody goes in an affordable way. Mm-hmm. And what do you think about those two techniques? Is there any difference or a significant difference? I know it's because when you find that this is the more efficient way and it's, for example, more sustainable, mm-hmm. then there is a big unmet need to translate it to the healthcare as well.
So thank you for your question. I understand where it comes from, your teledentistry topic. Through the articles that I've read and that did compare the cost, the results were not so significantly different. So generally the costs that they did measure was based on the number of appointments and the chair time and, for example, the pay of the dentist, but it wasn't at all relevant. So we did not go into measuring the cost of this.